Okay, well, we'll go ahead and get started. I want to start by just thanking everyone for being here. And worked with a lot of you from in the past, and I wanted to introduce myself to those of you who don't know me. My name is Therese Finn. I'm a registered nurse, and I work for Oregon Health Authority's Healthcare Associated Infection Program, or HEI program. And my role is working with facilities to prepare for and respond when we have high priority, what we call high priority multi-drug resistant organisms. And we're going to be talking about those today, and in particular, focusing on the risk that we have for these in the long-term care setting and what we can be doing to prevent spread to our vulnerable residents within our communities. So I'm going to go ahead and I'm going to turn my camera off so we don't have bandwidth problems. And I just wanted to mention that this is being recorded for educational purposes. If you have questions, would you please raise your hand? And then at the end, I have some time set aside for question and answer to address any questions and provide clarity, or figure out if there's things that I need to go back and do a little bit of homework on. So we'll get started. I wanted to introduce myself and my colleague from the eastern side of the state. This is, I cover the western side of Oregon, so pretty much from Oregon, from Washington down to California on this side of the mountains. And Elizabeth does the east side of the state. So we're resources for you, and our contact information is here. I'll also put links in a follow-up email that I will send to the team for dissemination, and as well as some resources in a follow-up email. I also want to mention that we have an amazing MDRO team. We have Adelina, who is our MDRO operations manager. On the left, Lex is our, on the upper right-hand side is the Healthcare Associated Infections Program and Epidemiology Manager. And we have two wonderful MDRO epidemiologists, Evelyn on the left and Heather Ritzel. We couldn't do this work without this amazing team. So our agenda today is really to focus in on understanding MDROs and their impacts in long-term care settings. We're going to discuss some details about our high priority MDROs, what those are in Oregon, and just to start introducing you to some of you to, if you don't know or are familiar with the terms, are carbapenemase producing organisms, or CPOs, and Candida auris. So those are our two classes of organisms that we categorize as high priority. And also, we're going to focus in on prevention of MDROs in long-term care, and what are the practices, I have a typo there, I apologize, to prevent the spread, and then also providing you with some resources to assist you in your day-to-day management of these types of organisms. So understanding MDROs. So multi-drug resistant organisms, for those who don't know, are germs, mostly bacteria, but also fungi. And these organisms develop ways to protect themselves from medications that we use to treat them, such as antibiotics and antifungals. These MDROs have an increased impact, particularly on those with underlying medical conditions, the very elderly, the very young, those with immunocompromise, and individuals who live in congregate settings. So just looking at that list, you can see that our residents in long-term care, because of their age and their underlying illnesses, often underlying illnesses are particularly at risk. When a resident has one of these MDROs, there are fewer treatment options for them when they become infected. So the CDC estimates that there's more than 2.8 million US MDRO infections per year, with about 35,000 deaths. So it's a significant impact with a considerable cost of more than $4.6 billion annually. So a lot of money goes along with these resistant organisms. So there are many types of multi-drug resistant organisms. I've been, exposed to this drug resistance for over 30 years now, and I've gotten to the point where I call it the march of the alphabet. Back in the day, we really were paying attention to MRSA and VRE, and then ESBL we became aware of, and then C. diff. So there really is this emerging resistance that we've seen over the last decades. Those individuals who are at risk for these multi-drug resistant organisms are, those who have serious underlying medical conditions, long healthcare facility stays, either acute care, LTACs, or long-term care. Indwelling medical devices, folks who have frequent healthcare worker contact, such as like diabetics who go to dialysis, and then also individuals who are exposed to broad spectrum antibiotics. Additionally, we pay close attention to residents, individuals who've had healthcare outside of Oregon, because these organisms remain rare in Oregon. So we have a lot of opportunities to learn about them and get experience with them. And also we know that patients with tracheostomies can also be particularly at risk. I said I'd talk a little bit about the MDRO impacts. So, these organisms increase healthcare costs. They increase morbidity or degree of illness and death in this population. They also increase antibiotic use and further development of antibiotic resistance. So the more antibiotics we use, the more risk we have for our pressure for developing resistance. There's also a bottom line impact in revenue loss. When you have residents who are going to the hospital for infections, you lose those bed days of care and that revenue coming into your facility. There's a potential for spread in your community, in your facility community. But also our patients or residents with these organisms are reservoirs of these resistant bacteria. And when we share those residents with other facilities, such as hospitals or other types of long-term care facilities, then, we are sharing those resistant organisms throughout our whole healthcare system. So long-term care really does I see it as kind of a center important spoke on that wheel of multi-drug resistant organisms. I do want to talk a little bit about colonization and infection with multi-drug resistant organisms. So on the left here, we have a picture of the iceberg, and above the iceberg is what we know of, those clinical cases. And multi-drug resistant organisms that cause an infection in the body usually causes symptoms. So fever, redness, swelling, a drainage. And when someone is infected with these organisms, they're more able to spread because there are more organisms. And then these folks can have, are at risk for more serious negative outcomes. With Candida auris in particular, 1 in 3 individuals who get invasive or infectious disease with Candida auris will not survive the infection. But aside from those clinical cases, we know that below the water is colonized cases. So there are, when we're colonized, that germ, that bug, can live normally in our body and help us with our respiratory tract, digest our food, and those kinds of activities, and not cause an infection, particularly if we're healthy, no symptoms. And we can remain colonized with these organisms for very long periods of time. But also through poor infection prevention practices, this increases the risk for spreading the organism. And we do know that someone who is colonized is at greater risk for developing an infection with those multi-drug resistant organisms. So one of the things I wanted to do is give you a window into the burden of MDRO in long-term care. And I'm going to talk a little bit about a study that was done in Southern California between 2016 and 2017 involving 28 nursing homes. And what they did was they went in and randomly selected 50 residents and to conduct cultures. And they did 20 cultures of residents and a resident and common spaces. And what they found was that over here on the right-hand side, you can see this circle. There were 4% of residents that they knew were previously known to be colonized. So that's what this number 1 shows, is those are the residents we knew in this study had colonization with these MDROs. And what they found was that nearly half of all residents in these 28 facilities that they conducted this study on were colonized with an MDRO. So it was a pretty significant finding and understanding of the impact of MDROs in the long-term care setting. What they also found was 74% of resident rooms and 93% of common areas identified contamination of these MDROs. So that really brings in the importance of the environment in transmission of bacteria in these long-term care settings. So to focus on specifically our high priority multi-drug resistant organisms, I want to focus on the left-hand side. We touched on the MRSA and the VRE. I want to focus in on the left side of the umbrella, below the umbrella here, for CPO and Candida auris. So CPO is a carbapenemase producing organism. I know it's a big word. I'm going to help you get some concept around it. And then Candida auris is that fungus that tends to have a high level of resistance. So starting to drill down into the CPOs, or the carbapenemase producing organisms, these are organisms that are resistant to carbapenem antibiotics, but they have a unique mechanism in order to be resistant, and that is that they produce an enzyme, or carbapenemase, which is a protein that destroys the antibiotics that we use. And these carbapenem antibiotics like ertapenem, meropenem, doropenem are particularly important because we use them to treat resistant infections. So they're kind of understood to be our last line of infection, last line of treatment antibiotics. These CPO producing organisms also have a unique way that they can share this resistance capacity with other bacteria. So I'm going to talk a little bit about that. But first, I want you to see that there's like this large category of carbapenem resistant organisms. And they can acquire that resistance in a number of ways, but it's important for you to recognize and when you see it. So typically you'll see CRE, so it's carbapenem resistant, Enterobacterales, carbapenem resistant Acinetobacter. So these are just different organisms. So those organisms are the ones that up here in the blue, they develop a way to resist resist the antibiotics that is different than what we're looking at with these CPOs. And that's what we're talking about with this red line down here at the bottom, where the bacteria can break down the drugs that we use to try to treat that infection. So that's a subset within that larger CRE category. And those are CPOs that produce the carbapenemase. And you'll recognize those in lab reports or handoff reports because it will specify that it is a CP-CRE, which means it's carbapenemase producing. So that's how you'll know it when you see it or hear it in a report or a handoff. I'm not going to go into a lot of the anatomy of bacteria because it's honestly over my head, but essentially the takeaway for this is that this is a cross-section of a gram-negative rod, and within the organism itself is a plasmid, and that plasmid has genes, and in particular with CPOs, those genes, it's a mobile genetic, what we call a mobile genetic element, which means that it can share easily that mobile gene with other gram-negative organisms. And there are different types of enzymes that are produced. So you'll see there that down here at the bottom, NDM, KPC. And for your purposes, it's not terribly important, but you may hear about it. So it's just the particular enzyme that's produced by that gene. So going back to this plasmid, this genetic element, the way that it moves from this cell, this bacteria, to another is by what I like to call unsafe sex between microbes. I hope some of you are giggling out there, but essentially what they do is, this is a donor bacteria, Pseudomonas up here at the top, and it has that mobile genetic element, and it sends out this pilus to another gram-negative organism, and it doesn't even have to be Pseudomonas. It can be E. coli or Proteus or Pseudomonas, whatever. And basically say, hey, hang out with me a little bit, and I have a wonderful package for you that I'm going to share. And it basically provides it with all of the information it needs to use that enzyme to fight the antibiotics. So these elements are easily shared among bacteria, and this is what has led to a rapid spread of antibiotic resistance. I'm not going to go into, again, a lot of detail, but I'm a visual learner, so I think, seeing this helps. And you can see KPC is the first one that we really started tracking here in the US. And we saw the first ones in 2001 in South Carolina and New York. And you can see within 9 years, the majority here, the majority of the US East Coast, Southeast, Southwest had all experienced these organisms. And then 7 years later, so within 16 years, we had KPC carbapenemase spread throughout the entire United States. So it didn't take very long. But now we have our Oregon cases of carbapenemase producing organisms. And what we're really fortunate here in Oregon, because these have been pretty rare. We had our first case a number of years after the first case in the US. So first case was in 2010. And it was pretty slow in getting some speed and pickup. The different colors on the bar are those different types of carbapenemase that the organism produces. But you can see even last year, by the end of December of 2024, we'd really seen only, I think it was 23 total cases in all of Oregon that last year. So they're still pretty rare. Now for Candida auris is a fungus or a yeast, so it's a kind of a cousin to Candida albicans, which I think we're all familiar with, athlete's foot and yeast infections. But some of the strains of Candida auris in particular are resistant to all available classes of antifungals. Candida auris produces a protein, which is an adhesin, which actually makes it sticky. So it's a particularly problematic in contaminating the healthcare environment and persisting as a colonizer on our skin. So it allows for easy spread. We saw our first case of Candida auris in Oregon in 2021. So this is really new to us here in Oregon. And as of today, we've had, knock on wood, less than 10 cases. I'm just going to run through this quickly just to give you a visual of how quickly this has spread across the United States. But you'll see here the first case was identified in 2016. They did a look back. They saw some additional cases that dated back to 2013. But New York had between 11 and 50 cases. So that's that color orange. And then the yellow is only 1 to 10 cases. Within a year, we had seen an increase to 50 to 100 cases in New York. And then Illinois is increasing. We've got more states that are seeing cases. Now we've got between 150 cases in New York and Illinois and increased cases in California. More states are seeing cases. By 2021, we've seen our first cases here in Oregon. And the good news, I don't have any data maps after 2021. I have to update the slide so they have that. But there is some good news in this unfolding. And that is that there are states that have been able to report no cases. And you can see Oklahoma here, some New England states, and as you can see in 2017, we had 9 cases in Oregon. So anyway, there are means to successfully reduce and prevent ongoing transmission of these organisms. So, we have a unique opportunity now to reduce resident and patient morbidity and mortality, so infection and death. We can protect our financial resources and reduce and slow the spread in Oregon. And by doing that, really improve our patient and resident and staff safety through good, robust infection prevention response and basic practices in our care settings. So what is doing our part for preventing the spread of MDROs? There's a number of steps that we should be thinking about or components of our strategy. Number one is educate administrators, infection preventionists, and our frontline healthcare workers. This is new to all of us, so we all have an opportunity to increase our awareness and our ability to respond and communicate. Communication is key with these organisms. We want to really look at what are our basic infection prevention practices and how can we do better. And then when we have residents with these organisms, what are the patient care strategies that we want to have in place to protect our other residents from spread? And that does have an impact on our routine environment of care, cleaning and disinfection practices. And also to be able to focus on strengthening our antimicrobial stewardship measures. the more antibiotics we use, the more likely we're going to have to increase our resistance, antibiotic resistance. So stewardship is very important. And then it's also important for you folks to know that when we have a new case and precautions haven't been put in place, that we targeted screening is requested and by OHA's HII program, because we want to make sure these organisms are not spreading in your population. Education, have a response plan for your first case if you don't already have it. Grow your local IP expertise. It's really worth investing in. You can start with the CDC certificate. I would recommend you have more than one person who has that expertise in your facility. There are national certifications that you can encourage for your staff. The first one is an entry level. It's called the Associate Certification in Infection Prevention and Control. And then there's another step up for long-term care certification in infection prevention, and that's targeted specifically at long-term care. And then there's that gold standard of CIC certification. And those last three are overseen by what's called the Certification Board of Infection Control. And they do certification for all, and it's a global certification. So it's a great way to move forward. I'd encourage you that when you're providing staff education for this, make it relevant to what they're doing in their everyday, duties and responsibilities, and then making it interesting, fun, and interactive. I've seen the use of escape rooms, scavenger hunts, and Jeopardy games to support and make education more fun. I have some of those resources. If you're interested, I'm more than happy to share. Just reach out to me and I'll send you what I have. Excuse me. So preventing gaps. It's really important before your resident arrives to get the right handoff information. So I'm going to run through some key things to pay attention to in that process. So as you're receiving your admission report, you want to listen carefully. What was the reason for hospitalization? Was it related to an infection? Were they treated for an infection during the course of that admission? Or if they're coming from home, do they have a history of these organisms? And then ask questions. Do an alphabet, do the alphabet check. Is this an MDRO? And if it's an MDRO, what are the letters, right? MRSA, VRE. Is it a CPO or a Candida auris? You want to pay attention. When they report, you also want to know, what type of infection did they have? Was it a wound? Was it urine? Was it blood? Was it a respiratory infection? Do they have devices? Because all of those things, all of those questions drive what kind of precautions you're going to put in place now that we have enhanced barrier precautions, right? So then you want to ask, is the wound healed? Is the resident still on antibiotics? So it's not, they're still being treated for it. And is the device necessary? One of the things I'm working really hard with long-term care facilities to do is, as you're starting to have those conversations for admitting, ask, can you get that Foley out before the resident comes to us? Because then it saves you a whole lot of struggle to have those voiding trials done before they get to you. And then once you have that information, then you can make the decision as to respond to contact precautions or enhanced barrier precautions. Do they need a shared room or a private room? And then you can place the precaution sign at the door for what's appropriate, and then ensure that the PPE is placed outside of the door where the resident is. I will be doing a targeted enhanced barrier precautions education next Tuesday. And I'll make sure to share that information with your team so that you can participate in that. You want to make sure those chart flags are really important because those who receive that patient from you, either from a hospital perspective or when you transfer them to another facility, also need the information to know what appropriate precautions are should be applied. And that chart that should also be communicated to transport personnel. And then communicate by reporting to others in your organization, you know, any challenges around it for your daily huddle, that kind of thing. So just remember that, you know, missed opportunities to put these barrier precautions and measures in place have consequences. You know, if a resident comes in and they're not put on precautions, we have to determine who's been exposed and what the risk is. So that triggers resident screening, and that's typically through rectal swabs for CPOs, which isn't pleasant. Then we have to notify residents, and that can often increase anxiety, worry for them, their family, and sometimes staff. So this all results in a significant burden of work for the facility. So it's important to figure out when you miss these opportunities, why and what can you do to ensure it doesn't happen again. So those, again, communication is key, chart flagging, handoff reporting. With these high priority MDROs, I strongly encourage both phone and a written transfer form for communication. And then internally participate in daily huddles, do in the moment education when you recognize hand hygiene barrier precautions or cleaning gaps. Just run through some other core infection prevention strategies. You know, it's important to know that as with any other MDRO, these high priority MDROs can be safely managed in your long-term care setting. They just require attention to detail and consideration for the right precautions and measures to put in place. We do that really by preparing staff, managing the fear and the anxiety through education and good compliance with our infection prevention program. So, you know, include standard work instructions. It may be helpful to develop decision support algorithms so you know what type of precautions should be used. But I would say if there's doubt and you don't have your IP available to consult with, use contact precautions, use that higher level, you can always back off. So use contact precautions for anyone who's infected with an MDRO, including high priority MDROs, anyone who has diarrhea, wounds, secretions, or excretions. Sometimes we'll use transmission if additional cases or transmission is suspected. And then other conditions such as C. diff, norovirus, or scabies. I would like to mention that do a timeout before you take someone off contact precautions and put them on enhanced barrier precautions. A risk assessment is really important to find out what's unique about that resident. You know, do they have ongoing diarrhea, behavioral, cognitive problems? And the goal for that really is to identify the risk factors for spread to your other residents in the unit so that you can mitigate those risks wherever possible and allow them to live normally within your community. And then you go ahead and put them on enhanced barrier precautions for those key things of, you know, colonization with MDRO, devices, and open wounds. And again, I'll be talking more about this in detail next Tuesday. I never talk about hand hygiene practices with infection control without talking about hand hygiene. I want to call out here to really make sure that you're engineering the environment to facilitate hand hygiene. Make sure those dispensers are available at the entry to rooms and apartments and are available in your common spaces. It's also important to include residents in your hand hygiene opportunities. Sometimes, they are not able to wash their hands after toileting. They may have cognitive impairments and physical limitations, which your staff can support by assisting with soap and water hand hygiene and the use of alcohol hand rubs. Include family, residents, and staff in education. Make sure that you're cleaning and disinfecting with an EPA list P germicide. Make sure you have good equipment management practices, and then addressing your wastewater contamination sources. Antibiotic stewardship is really important. It's a significant driver of resistance, and our studies are showing that 40 to 75% of antibiotics prescribed in nursing homes may be unnecessary or appropriate. I'm going to be sending you along some links for some friendly, user-friendly resources and some core elements for your stewardship program. And then importantly, if you have a new case of a CPO or a Candida auris, know that you are not alone. A single case of either of these triggers a response from us here at the HA Out program. And those of you who have worked with me and Evelyn and the team in the past know that this is not a regulatory, it's really to educate and support your facility to ensure we don't have ongoing transmission. That a response typically includes additional testing of additional residents, me or Elizabeth or one of the IPs doing a responsive infection control consult. And if you would like to have a proactive consult, talk with one of us about how you can improve your program, there is a way for you to request a proactive consult, and I will send you a link to that as well. And that's here on our resource page. So again, Elizabeth and I's contact information, I'll leave that up here for a little bit, and I will open it up for any questions, and really welcome questions, because I have as much to learn from you as you may have to learn about this. So please, I'm going to stop the recording and then take questions. I can figure out how to stop the recording. Sorry, I can't figure out how to stop the recording. Oh, there it is. Okay.